My name is Jorge Cortes. I am currently the director of the Georgia Cancer Center at Augusta University in Augusta, Georgia. I've been doing clinical research and largely in CML for many years. I've been part of the early clinical trials from the very first one, imatinib, to the most recent ones in all stages of their development. I have a large clinical practice in CML as well. So I've been very, very heavily involved with CML for many years, even as a trainee. The great majority of patients today that are diagnosed with CML, at least in the Western world, are diagnosed as in chronic phase, and very frequently asymptomatic. They get a blood test for other purposes, and it shows that the white cell count is elevated, and that prompts a full workup. We have right now 5 tyrosine kinase inhibitors approved for initial therapy for CML, which is how we manage patients. Well, nowadays, everybody gets a TKI as initial therapy. The first one that was approved is imatinib, then came the second generation, dasatinib, nilotinib, and bosutinib, and more recently, asciminib has been approved for the same purpose. I think they're all good. Of course, with new subsequent generations, we get additional benefits, but we acknowledge that imatinib is a very good drug and still has some good value. More and more, the goals of therapy in CML initial diagnosis are evolving from improving survival to nowadays trying to get to the best quality of life and treatment discontinuation as the treatments are getting better. Yeah, so the OPTIC study was a study of Ponatinib in patients that had received 2 or more prior tyrosine kinase inhibitors or who had the mutation T359, which is the current indication for Ponatinib. And it explored 3 different starting doses of Ponatinib: the standard, which is 45 milligrams daily, and 30 milligrams daily, and 15 milligrams daily as the exploratory arms. And the rationale for that is that when Ponatinib was approved in these kind of patients, the efficacy was very good. We're very happy about the high rates of response that we can get with Ponatinib, but we recognize that there was the occurrence of arteriocclusive events on a significant number of patients. So in trying to see if alternative doses could maintain the efficacy and lower the risk of these arteriocclusive events, this was designed. So patients were randomized to each one of these 3 starting doses. And one of the most innovative elements of this design was that once patients achieved a response, and for the purposes of this study, a good response was defined as BCR-ABL of 1% or less. Once the patients achieved that level of response, they were required to reduce their dose to 15 milligrams daily, even if they didn't have any adverse events, so a response-directed dose adjustment. So that was the rationale and the design of the OPTIC trial. The primary endpoint was the response at 12 months that had been already reported. And as you mentioned, this is the 5-year follow-up, which is important in terms of seeing any later duration of response, differences in response, and as well as later adverse events that may have occurred. So in terms of the response, that rate of response of 1% or lower, which had already been shown to be significantly better with 45 milligrams at 12 months, remained significantly better at the 5 years. So the rate had increased to 60% for the patients treated with 45 milligrams, and it was 40% for those treated with the lower doses, 30 milligrams or 15 milligrams. The other levels of response, which were also analyzed, MMR, MR4, MR4.5, they all also favor the dose of 45 milligrams as a starting dose. So all in all, confirming the fact that 45 milligrams daily is the preferred dose. There's no difference in survival, but that was just a secondary endpoint. And I think that was probably part of the reason for that is because overall the survival was very good. but clearly the response rate is much better. In terms of the safety profile, dose reduction once the patient responds has greatly reduced the risk of arteriocclusive events. Originally in the PACE study, up to 30% rate was reported. Now with 45 milligrams, it's only 14%. And when you adjust for exposure, it's 4 per 100 patient years. And it's very similar to the 30 milligram daily dose, which is 3.8. And the reason for that is because since the 45 milligram dose cohort responds faster, then the dose adjustment brings the dose down quickly, and that decreases the risk. One other element that was described in this report, the 5-year, which is something that we reported for the first time, is what happens with the mutations on patients who start with mutations or who develop resistance on Ponatinib. And what we found is that the patients who started with mutations, many of these mutations were no longer detectable at the end of treatment, even when the patients had resistance to Ponatinib, showing that Ponatinib has that potential to eliminate resistant clones that have mutations. But perhaps the most attractive element of these was that patients that started with no mutations, we did not see emergence of mutations with the 45 or even with the 30 milligram starting dose. Only one patient among the patients in these two cohorts had a mutation. So there's almost 200 patients overall, and only one patient treated at 45 milligrams had the emergence of a mutation. With the 15 milligram cohort, we did see more patients develop a mutation, 4 a T359 and 1 a different mutation. And then patients who started with T359 compound mutations can become an escape mechanism, a resistant mechanism, something that we already knew that compound mutations can be particularly difficult even for Ponatinib-treated patients. So overall, these results confirm the efficacy of Ponatinib, show that 45 milligrams daily provide the best benefit-risk balance, and also that it has the potential to prevent the emergence of mutations on patients that start without any mutations. One thing that I would mention is that with these results, number one, we need to recognize that the way we use Ponatinib is different now. We need to remember these lowering the dose once a patient responds, and that certainly, although we have other alternatives now with asciminib, Ponatinib is still a very valuable drug that helps these patients, and it should be considered on patients that are eligible for Ponatinib.